Good evening. Good evening, everyone. And last week we had the initial session. It was related to ISP definition of pain, the basics of pain mechanisms, WHO definition of palliative care, and multimodal approach to pain management. And we know that even if we know the pain mechanisms and the definitions and the treatment, the part will not be complete unless we know how to assess pain and to assess in a quite systematic way. So this time we have the learning outcomes as assessment of pain, diagnosis of neuropathic pain and sympathetically mediated pain, discussion on nociceptive and neuropathic pain, and regarding visceral and bone pains, and introduction to adjuvants. This time our faculty is Dr. Jewell Jospeh. He's an eminent faculty. He did his MD radiotherapy from Government Medical College, Thrissur, and currently is assistant professor in CMC Vellore. He's also faculty of Impact HN course with the National Cancer Grid. His areas of interest are community palliative care and home-based care. Dr. Jewell, over to you.
Thank you, Dr. Manu, for that introduction. Good evening, all. I hope I am audible. So,
yes, sir. A little more louder would be good, sir.
Yeah. Okay. So I'll share my screen now. I hope it's visible.
Yes, sir.
Just a minute. I'll just. Sorry. So once again, very good evening to all. So today's session we'll discuss about assessment and certain types of pain. So as you must have you must all know, and you must have heard in the first session, pain, the scientific community no longer considered as just a sensory like a sensory experience or just a simple sensation. So rather we actually consider it as a whole experience. Rather than being just a feeling or a sensation, it is actually considered as a pain experience. So traversing various domains of emotional, physical, psychological, all those things. So it's like basically going to a restaurant and ordering food. So even though we go to the restaurant for primarily having food, the ambience also plays a major role, right? The music, the lighting, sound, and all those things. So it's basically like that. So in lines with the current understanding, so the definition of pain has also recently changed. So the long-standing definition of pain by IASP, which was proposed back in 1979, was that an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So uh, after almost like 20, 30 years, 30, 40 years, it finally changed in 2020. Although it was proposed in 2018, it was officially changed in 2020. So they have changed it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So basically what they are trying to say is that for pain to occur or the pain experience to occur, an actual potential tissue damage is no longer a necessity. So that basically acknowledges the various other domains of pain rather than just being a primary sensation. So this is something known as the pain matrix, the diagrammatic representation of something known as the pain matrix. So this basically shows the various regions of the brain which are interconnected in the perception of the pain experience. So you can see that it is rather than being a primary sensation, it is actually a coordinated experience with multiple centers in the brain coordinated together to form that pain experience. So although the scientific understanding of the pain matrix is more recent, in a palliative care setting, the concept of total pain has been advocated long back by the founder herself. I mean, the founder of palliative care, Dame Cicely Saunders. So she has actually put forward the concept of total pain. So basically, this is a representation of the various domains which are associated with the perception of pain. So it has pain experience as a psychological, physical, social, and spiritual domains. So any of these domains can actually contribute to the total pain experience. And also whenever we are addressing pain, it is important to consider all the domains which can contribute to the experience of pain. So having said all this, it is very clear that since we have established that pain is a very it's like a multi-dimensional experience, a multi-domain experience. So it is natural to understand that pain is subjective. So it's always important to keep in mind whenever we are assessing pain is that it is subjective. So pain stimulus, which may be uh, uh, very very distressing to one patient, may not be as distressing to some other patient. So it is basically a very subjective experience. So before going into the assessment, I would like to just give you a context or a background regarding how or and where we are in assessing cancer pain and how efficient are we in managing cancer pain. So this is a data which was published in 2016, which shows the prevalence of cancer pain in various stages of cancer. So you can we can see that cancer pain is a major problem in various stages of cancer, right from stage 1 to stage 4. Obviously, as the stage increases, the prevalence of cancer pain also increases. And in our clinical practice, we often find that pain is most commonly a triggering factor for consultation or the patient to come to the hospital. So starting from stage 1 with the prevalence of 23.8%, it goes up to 44.2% in stage 4. So in all stages combined together, around half the cancer patients suffer from cancer pain. And if we take the advanced stages alone, so around 70% of the people or the patients suffer from cancer pain. And again, another important thing to notice is that the prevalence of cancer pain is not limited to the disease process alone. So again, from the same paper, the data from the same paper shows that cancer treatment can be a problem before, during, and after treatment. So around 55% of the patients had pain during cancer treatment, and 39.3% of the patients had pain even after curative cancer treatment. So obviously in advanced and metastatic cancer, the incidence is as high as 66.4%, and the percentage of moderate to severe pain is 38%. So we can see that all through the cancer experience, right from the diagnosis, treatment, and the surveillance and the post-treatment period, pain is actually a major problem. So yeah, now that we know that cancer pain is a major cause of morbidity in our cohort of patients. So the next question to ask is there a gap in the way we address and treat cancer patients? So the answer would be yes. So this is another paper which was published in 2018. This is from India. Uh, it's based the paper basically the review basically looked at the prevalence of pain and its management in 4 regional cancer hospitals in tertiary care centers in India. So they have found that in cancer patients having mild pain, only 50% of the patients received adequate pain relief. When it comes to moderate pain, only around 20% of the patients receive adequate pain, and in severe pain, only 5.7% of the patients receive adequate pain relief. In other words, around 94% of the patients who are having severe pain are not getting inadequate pain relief. So another important thing to notice, the data which I showed previously from that 2016 paper was actually a follow-up paper to another paper which was published in 2007. So you can see that the prevalence of cancer pain during the various stages, before treatment, during treatment, and after treatment, has not changed much. So it is almost the same. So even the percentage of moderate to severe pain has increased from 33% to 38%. So there may be multiple factors leading to this, but just think about the developments in curative and treatment in the disease modifying treatments that has happened from 2007 to 2016. I think the cancer treatment itself has gone, disease modifying treatment itself has gone forward by leaps and bounds. So it is unfortunate that, so even with all these new developments and the improved survival and the newer agents for treatment, the issue of cancer pain itself is actually largely not addressed. The prevalence has not been changed much from 2007 to 2016 in a time gap of 10 years. So now that we have seen that cancer pain is a major morbidity, and it is in a large sense it is not being addressed properly. So what can we do about this is that all patients with active malignancy, they should be routinely screened for cancer pain. And again, the patients who report cancer pain, they require a more comprehensive assessment and specific treatment regarding to their complaints. Having said that as a context or an introduction, so we'll go to the clinical evaluation of pain. So the assessment of pain. So the aim of basic assessment is to facilitate our management or treatment of the pain, right? So in palliative care, not specifically related to pain relief, in all symptoms in palliative care, so we basically follow a three-step approach. So it would be correct the correctable, non-drug measures, and drugs for symptoms. So this is basically the criteria that we follow for every symptoms. So the idea of assessment of cancer pain would be to give us information about the three steps. So correct the correctable. So a proper assessment of cancer pain would let us know the factors that can be reversed or corrected in that particular patient. Again, the non-drug measures. So if we assess the patient properly and if we get information regarding what aggravates and what reduces the pain, so we can have certain non-drug measures, non-pharmacological measures like lifestyle modifications and all those things that will help us in improving the pain experience of the patients. And finally, when we understand the type of pain and the severity of pain, that will help us in deciding and prescribing the drugs for a particular patient's pain symptoms. So again, aims of assessment would be to identify the characteristics of pain, pathophysiology of pain, etiology of pain, and other factors contributing to the pain experience. So before going into the assessment of pain, so these are the certain general principles we need to follow while assessing the pain. The first thing would be to establish a trusting relationship with the patient. So that is important because in a place like India, we often feel that the patients may not be as vocal about, so it can be two extremes, but there are a lot of patients who are usually not vocal about their pain symptoms. So, and there are a lot of patients who actually believe that pain is actually a part of the disease process. So they have to go through the pain during the treatment. So they don't usually give much importance to that, and various other factors are there. So unless we have a trusting relationship with the patient, a good rapport with the patient, so they may find it difficult to open up to us regarding their complaints. So rather than going into a more specific questions in the beginning, so always it is important to begin with an open question. So for example, when a patient comes to us, so rather than going directly to how is your pain and where is your pain, we can just start with how are you feeling today, an open question like that. So that actually gives patients more space to open up and more ways to go rather than directly pointing them towards the particular complaint that we need to elicit from the patient. So I understand that this may be difficult with all our time constraints and the number of patients we need to go through in a particular day, but whenever possible, so it's always advisable to go start with an open question before going into more specific questions. And it's always advisable to encourage the patients to do most of the talking, because the thing is, one important thing I would like to share is I did my post-graduation in radiotherapy, and I came to palliative care in 2019. So I have been practicing palliative care since then. So one of the first tasks my head of the department gave to me when I came to palliative care is to see how long I can actually listen to a patient without interrupting. So this is an exercise that we can all try in our clinical practice, and to my surprise, I found that it is really very difficult to listen to the patient continuously without interrupting. So we always try to sorry. So we always try to interrupt and to direct the patient. So, but that actually was a very insightful exercise. So So when we really allow the patient to talk, so I think they'll usually give more information and usually all the information that we need from that in relation to that particular symptom. So again, watch the patient for visual clues. So as I mentioned earlier, there are a set of patients who will find it difficult to open up about their symptoms. So it may be because of language barrier or various other things. So it is always important to look for visual clues as well. And it is always important not to assume. So as I mentioned earlier, so as we discussed earlier, pain is a very subjective experience. So when we it's a common thing that when we see a lot of patients, so we usually attribute the severity of symptoms to the disease process itself. So for a particular lesion of this size, so this is very unusual for a patient to have this much of pain, so we may feel that he or she may be exaggerating. So it is always important not to assume and always keep in mind that pain is a very subjective experience. So again, continuing with the general points, so introduce ourselves clearly. It is again a way of building a rapport, maintaining eye contact, explain whatever we are doing. I mean, if the patient is not clear about our questions or the information that we are giving, always important to explain, avoid medical jargons and all those things. Summarize, because when we are providing a large set of information or a large chunk of information, patients may feel it difficult to follow, especially when they are not from a medical background or from a lower educational status. So in between, we can stop and summarize so that the patient can exactly understand what we are trying to convey. So as we mentioned earlier, don't assume, avoid patronizing or false reassurance or comparison. So these things are very important. So patronizing, as I mentioned earlier, so don't assume that we know what the patient is going through, and always keep in mind that the perceive according to the disease status of the patient may not be the actual experience the patient may be going through. And it's always better to avoid false reassurances such as everything will be all right, so we'll take care of all this. So if you feel that it is always important to empathize with the patient, but it is always important to maintain a level of honesty rather than just giving a blanket statement of everything will be all right. So maintain honesty, but at the same time empathizing with the patient is always important. And again, since pain is a very subjective experience, please avoid comparison. So I am myself guilty of making the statements multiple times during my PG days. So this common statement I used to make is people with even more severe disease who are actually doing quite well. I mean, you should also, so that statement, that kind of statements we usually should avoid, because again, to repeat again, pain is a very subjective experience. So comparison don't have any place in our assessment. So always advisable to use appropriate language, a language that the patient can understand, and also to avoid medical jargon. So again, I'll just highlight two important points when we are assessing the pain. The first point would be to listen. So I'll just play a video which is from the the person that we mentioned earlier, Dame Cicely Saunders, who is actually the founder of Palliative. We'll just listen to this video.
I'm often asked, what is the first thing you really want to say? I'm often asked, what is the first thing you really want to say to somebody going into medicine or moving into palliative care? What is the major commitment? And I'm sure the answer is simply listen to your patients. They'll tell you. They'll tell you what they need. They'll tell you who they are and what they can achieve. I'm often asked, what
Yeah, so this is the first thing that I would like to highlight again. So if we can just summarize all these general points that we talked in the previous slides, the first point of summarization would be to listen to the patient. So I'll just coming to the next point, I'll just give you a clinical scenario. The first is a 54-year-old gentleman who is a known case of carcinoma lung with bone mets, comes with a pathological fracture of right humerus. Patient grimaces in pain, has tachycardia and sweating. So he says that he is in severe pain. So that is the first scenario. Second is 60-year-old gentleman, case of carcinoma head of the pancreas on chemotherapy for the past 4 months. Patient says that he is in severe pain, but he doesn't appear to be in pain. He looks tired and gloomy and has decreased appetite and sleep. So I just wanted to know, so among which of these patients do you think that patient actually has severe pain? So if we can actually put the responses in the chat box. Yeah. So yeah, it's both. I
both.
mean, yeah. So I just wanted to highlight this point. So again, in this context, I would like to have a differentiation between acute pain and the chronic pain. So acute pain is something that we have all experienced in our life. So suddenly if there is a fracture or a trauma or something. So there are uh, certain features, clinical features that we usually attribute to severe pain. Like the patient can be tachycardic, patient may be grimacing, she may be there may be sweating, and all those things are there. So, but in chronic pain, the situation is a little bit different. So, especially in our patients, chronic pain is a very important thing. So, chronic pain has an ill-defined onset and a prolonged fluctuating course. So, again, overt pain behaviors like grimacing and sympathetic hyperactivity are typically absent. Vegetative signs like lassitude, sleep disturbance, anorexia are more common, and patient usually does not appear to be in pain. Appear to be in pain in the sense patient will not exhibit the typical signs that we attribute to severe pain. So the only definitive way to determine the presence of pain is to obtain a verbal report from the patient. So having said that, I am coming to the second point of my summarization is to believe. So this sentence is from Dr. Robert Wycross, who is another pioneer in palliative care. Pain is what the patient says hurts. So if the patient says that there is pain, we should believe that there is pain. So before going into the proper assessment tools and all, this is the second point that I wanted to highlight is to believe. First is to listen, second is to believe. And the third and final summarization point regarding the general principles of pain assessment would be to have empathy and compassion. So it is important to have, the patient should actually feel that the person sitting in front of him or her is actually there to help him or her. So I myself find it very difficult to practice this because of a lot of other things. We may be tired, uh, there will be a lot of patients waiting, so we may have multiple things to sort out. So but it's always important to have empathy and compassion so that the patient feels that we are there for him or her, and so that they'll feel more confident to open up to us regarding their symptoms. So the summary of all the slides that we have covered until now is believe, listen, and have empathy and compassion. So having said that, so now we will go to the various steps of cancer pain assessment. So the first thing would be to have a careful history of the pain complaint, to place it temporarily in the disease history. So I did exactly when it started and how has it been going on to the in relation to the disease history. Second thing would be to assess the characteristics of each pain, clarifying the temporal aspect of pain, the timing aspect of pain. When did the pain start? When is the pain increasing? When is the pain decreasing? And all those things. Listing and prioritizing each complaint, evaluating response to prior and current analgesics and disease modifying treatments, evaluating the psychological state of the patient, past medical history and addictions, careful clinical examination, necessary investigation, and designing a therapeutic approach. So this would be the common skeletal framework of our pain assessment. So the first thing would be, as I mentioned earlier, so all these things would help us in the management. So basically, we are primarily concerned about the pharmacological management in this presentation. The previous thing would be, as I mentioned, there will be correcting the correctable non-pharmacological measures and pharmacological measures. So to give pharmacological measures, we should actually know the type of the pain and the severity of the pain. So I will now go on to various tools and methods to assess the type of pain and severity of the pain. So this temporal factors and increasing and decreasing, what aggravating and relieving factors, etc., will help us in modifying the other things. And characteristics of the pain and the type of pain, severity of pain, etc., will help us decide the pharmacological management. So the characteristics of the pain can be the common mnemonic we use is PQRST. P is palliative factors, the factors which help the pain, relieve the pain. Provocative factors, the factors which aggravate the pain. Quality of pain, the type. Quality means the type of pain. radiation is where the pain radiates to, severity and impact, and temporal factors is the time related factors. When was the pain started? How is it going? When is it increasing? When is it decreasing? The diurnal variation and all those things. So although we say PQRST, the order to go would be to TQ, TS, RQP in the reverse order. So when did the pain start? How severe is the pain? Is it radiating to somewhere? So again, aggravating and relieving factors. So we will start with the time and then go. So for the mnemonic sake, we say PQRST, and we usually go in the reverse order when we are asking the patient regarding this pain. So as I mentioned earlier, for designing the pharmacological therapy, we need to assess the pain intensity and we need to assess what type of pain it is. So we'll go into detail regarding the tools for assessing pain intensity. How severe is the pain? So basically what we have here is two set of pain scales. There are unidimensional tools and multidimensional tools. So unidimensional tool is basically just uh, if measuring the severity of the only one question we ask is how severe is your pain. So we are not going into the other characteristics of the pain. We are not going into how the pain is affecting the patient's various activities. We are not going into the type of pain. The only thing we are assessing in a unidimensional scale is the severity of pain. So the examples would be numeric rating scale, phases rating scale, and visual analog scale. We'll come to each of them in detail later. The second group would be the multidimensional scales. Examples would be McGill pain questionnaire and brief pain inventory, where they actually branch out to various other dimensions of the pain also. For example, what type of pain exactly it is, how is it affecting the various activities, etc. So this is the most commonly used scale in clinical practice, the numeric rating scale, which is again a unidimensional pain. The only thing that we ask the patient is to let us know the severity of the pain on a scale from 0 to 10. So 0 is basically no pain and 10 is the most severe pain, most severe imaginable pain. So again, they can actually mark 1, 2, 3 up to 10. So 1, 2 and 3 we usually tell as mild pain, 4, 5 and 6 moderate pain, 7, 8, 9, 10 as severe pain. So what we usually ask when the patient is, when they come to us, the current pain. So we ask the patient to rate the current pain, the most severe pain in the past 24 hours, and like the uh, least pain the 24 hours can also be asked. So this is how we usually use the scale. So in subsequent visit, we again actually ask the patient to rate again so that we have an objective measure of how the pain is progressing, or I mean how the pain is going, whether it is improving or decreasing, which help us in modifying our pharmacological and other therapy. So this is the numeric pain rating scale. This is the visual analog scale. This is very similar to numerical rating scale, but we don't have specific set of numbers here. So this is again a continuous line starting from no pain at all to excruciating pain. So basically we ask the patient to mark somewhere in this line according to the severity of the pain. So the more the marking is towards this side would be more severe the pain. So again we repeat it in further visits so that we'll be able to assess how the pain is progressing. This is the visual analog scale. So the third thing would be Wong-Baker Phaser scale. So this scale was initially started for children who are not able to communicate. So basically what we do here is we see the facial expression and assess the pain according to the facial expression of the patient. So now this pain scale is actually used for all uh, people above the age of 3 years. So they have a dedicated website for this pain scale, and it is widely used. The thing is, we are not asking the patient, we are just assessing the visual clues and scaling the pain according to that. So this can be used above 3 years for any patient. So the limitations would be uh, the facial expression may not always match the pain severity as we mentioned in chronic pain. So, but this is again a useful scale when communication is difficult actually. So all these scale as I mentioned earlier are free to use. We can download it and use it in our clinical practice without any permission and all those things. Wong Baker actually, if you go to the website and register, you can actually download it with their permission, with free of cost. So this is an idea. There are other scales also, but this is the basic idea of a unidimensional pain scale. We are just assessing the severity of the pain alone. So now we are coming into multidimensional questionnaire. So this is the first example would be McGill pain questionnaire, which was developed from the McGill University. The first draft which came out in 1975. This was the original McGill pain questionnaire which actually came out. So this is the modified version that we usually see. So McGill pain questionnaire basically have the severity of the pain and also the position of the pain. So the severity of the pain, we can actually score it, and they have a detailed section regarding the type of pain. So jumping, fluid, all the descriptions like pricking pain, sharp pain, pinching pain, and all those pains are there. So there is a region, there is a body diagram also where we can actually mark the site of the pain. So this is about McGill pain questionnaire. So another multidimensional questionnaire which is widely used is the brief pain inventory. This is actually first came out in 1983. This can be downloaded in the MD Anderson Center website. It is actually paid. We'll come to that in later. So this is the original brief pain inventory which came out in 1983. This is the brief pain inventory short form which we usually use. So we can see that there is again a body diagram here. There is a numerical rating scale here, and in the least in the past 24 hours and the most in the past 24 hours, as we mentioned in case with the numerical pain rating scale alone. So they are also asking about an average pain and the pain right now. So there is also a section which actually see how the pain affects the general activity of the patient, general activity, mood, walking ability, and all those things. So this is actually brief pain inventory short form. These are the two major things which are commonly used. So brief pain inventory and McGill pain questionnaire are validated pain scales. So brief pain inventory is psychometrically and linguistically validated in various languages and linguistically validated in all, basically like a lot of Indian languages, Hindi, Malayalam, Tamil, Telugu, Kannada, Marathi, Bengali, etc. McGill pain questionnaire has a validated translation in Hindi. So the thing is, MD Anderson we can actually McGill pain questionnaire is free to download. So we can actually go to their site and download it after filling up a form. MD Anderson Cancer Center actually charges $100 as a convenience fee for this. There is an option to waive off that fee if we are a student and if one is a student and if one provides a recommendation letter from the head of the department. So otherwise $100 will be charged. So this is something like a very extensively studied tool, validated tool, especially brief pain inventory have multiple translations which are validated. The role of multidimensional questionnaire in clinical practice is primarily limited by the time that we have. So again, these things are both McGill pain questionnaire and brief pain inventory can be self-employed. We don't actually need a medical care provider to help the patient fill these. Patient themselves can fill these. So all those barriers are there. The language barrier, if we can actually translate to the local language, it is again easier, but patients may not be able to read and write. So the primary limiting factor would be time in our basic clinical practice. We ourselves don't use multidimensional questionnaire in palliative care practice. We usually use the numerical rating scale with other questions. So the primary area of usage for this multidimensional questionnaire would be in the context of a study. But again, if we can incorporate it into our clinical practice, that is well and good. So this is about the multidimensional question. So basically, to give an idea about how multidimensional and unidimensional pain rating scores work, assessment scores work. So this is LCC and distress thermometer, which you must all be aware. So as I mentioned, this is actually not a pain screening tool, but as I mentioned earlier, since pain is a total experience, so it is always useful to measure how distressed the patient is. So NCCN thermometer is a way of measuring the distress of the patient. So they have this is the distress scale, and this gives an idea about the cause of the distress. So distress scale we rate from 0, thermometer we rate from 0 to 10. Again, 0 is no distress and 10 is extreme distress. Any score equal to or more than 4 is considered as moderate to severe distress. Those patients will require like a professional evaluation with a psychologist, medical, social worker, etc. Anything less than 4, the medical team along with the available resources can manage. So the second section would give us an insight about the cause of distress, like practical problems, family problems, emotional problems, etc. Spiritual, religious, physical problems. So this is something like a useful tool, although this is not a proper pain assessment tool. This is always helpful to assess how distressed our patient is. So this is NCCN distress thermometer. So while assessing pain, it is also important to consider the temporal factors. So in cancer pain, especially chronic pain, so we actually should address two aspects of the pain. So one is the background pain, which is actually constantly present throughout the throughout the day. So the patient will have a constant background pain throughout the day. And one more important characteristic of chronic pain is that in addition to the background pain, there will be breakthrough pain in between, like these spikes in between. So whenever we are prescribing medications, we should address this background pain and breakthrough pain. So while assessing, we have to ask about the background pain and breakthrough pain and all the temporal factors so that we will be able to treat them better. So this is about the temporal factors. So these are the overview of some tools that we usually have. So now we'll go to the pathophysiology of pain. So pathophysiology of pain, so basically the type of pain, as I mentioned earlier, the assessment is to let us know the severity and the type of pain. The severity of pain we actually measured through all these unidimensional, multidimensional scale. Now we'll go to the pathophysiology of pain. Pathophysiology is basically the etiology and type of pain, so which will help us uh, 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 design our pharmacological approach and various other approaches so that we can actually tackle that particular pain. So basically, pain is divided into nociceptive and neuropathic pain. These are the broad classification about the type of pain. So nociceptive pain is basically where there is a tissue injury, and neuropathic pain is where there is a nerve injury. So nociceptive pain is again divided as somatic and visceral. So somatic would be bone and soft tissues, visceral would be the hollow viscera, neuropathic would be nerve injury. So we'll start with the neuropathic pain and then go into the somatic pain. So neuropathic pain is basically the pain which occurs when there is a neoplastic invasion or compression of spinal cord, nerve root, plexus or peripheral nerves. So these are the tumor related factors. So there can be leptomeningeal mets causing pain, cranial neuralgias, paraneoplastic syndrome. So all these are tumor related factors. So it may not be always tumor related factors, it can be treatment related also. So especially chemotherapy drug related. Platins and taxanes can cause peripheral neuropathies along with various other drugs. Radiotherapy, especially radiotherapy to breast, can cause brachial plexopathy, and all those things can be there. So it can be either tumor related or treatment related. It is said that 40% of the patients with chronic cancer related pain have a neuropathic pain syndrome. So identifying neuropathic pain is basically an important thing so that we will be able to treat it better. So there are various tools and screening tools for identification of neuropathic pain. So this is something what is known as a DN4 questionnaire. So all the neuropathic pain identification tools uh, basically rely on uh, two things. One is the characteristics of the pain and certain clinical signs that we can elicit in case of neuropathic pain. So the characteristics of the pain would be the typical description of the pain. It may be burning pain, tingling pain, pins and needle sensation, numbness, itching, and all those things would be there. So that is the characteristics of the pain. Certain clinical signs would be two important clinical signs are allodynia and hyperalgesia. Allodynia is basically an altered sensation. So that basically means a non-painful stimulus can be perceived as a painful stimulus. That means that a normal touch or pressure, the patient can perceive it as a painful stimuli. Hyperalgesia is increased sensitivity to pain. So a minor painful stimuli may be attributed as a severe painful stimuli. So there are various scales, various screening tools for neuropathic pain, but all of the scales take into account these two things: the description of the pain along with these clinical symptoms, these clinical signs, allodynia and hyperalgesia. So this will help us identify neuropathic pain. So scoring the neuropathic pain, we actually use the same tools for scoring as all the other pain. So we just score according to the severity. So like numerical rating scale or all those things. So we just need to identify the type of pain, neuropathic pain, and then score it accordingly so that we will be able to address it better. So one more important thing which is usually connected to the neuropathic kind of pain would be sympathetically mediated pain. So this is a condition where there is an abnormal coupling between sympathetic efferent and nociceptive efferent neurons. So basically what happens here is in response to a painful stimulus, an abnormal sympathetic activation happens and there may be sensory, vasomotor and pseudomotor symptoms. So sensory symptoms will be hyperesthesia and allodynia as with any other neuropathic pain. Vasomotor symptoms like temperature asymmetry, skin color changes, skin color asymmetry, etc. happens. Pseudomotor things like edema, sweating changes, sweating asymmetry happens. So what happens here is there is a painful stimuli. In response to that, there is an abnormal sympathetic activation to that affected area. So sympathetically mediated pain is considered to be one of the causative pathophysiological factors for what is known as complex regional pain syndrome, which is usually very rare, but it is always useful to know regarding these things. So this is sympathetically mediated pain. So now we have completed neuropathic pain. We'll come to nociceptive pain. So nociceptive pain, as we mentioned earlier, basically is when there is a tissue injury. So it can be either a somatic pain where there is a soft tissue or bone damage, and visceral pain. So again, as with neuropathic pains, there are certain characteristic descriptions of the pain that we usually come across in these patients. So nociceptive pain is usually described as an aching pain, throbbing pain, or dull pain. And visceral pain usually is described as a twisting kind of pain and colicky kind of pain. So among nociceptive pain, there can be soft tissue and bone pain, and in that bone pain needs a specific mention. So in bone pain, in malignancy, it can usually happen with direct invasion, secondary pathological fractures, damage to adjacent structures, etc. It is always important to keep in mind that although bone pain is classified as a somatic kind of pain, uh, like a nociceptive pain, it usually has a neuropathy component as well. The neuropathy component of bone pain can be because of direct nerve injury, because of the various fractures or all those things, and consequent pathological sprouting of sensory and sympathetic nerve fibers. So in response to the nerve injury, there may be new sprouting nerve endings carrying sensory and sympathetic stimulations, which can actually trigger the bone pain, the neuropathic component of the bone pain. So there can be neural changes, complex perineural release of growth factors and chemical mediators, and there is also mechanical distortion related to microfracture. So all these would result in bone pain, and it is always important to keep in mind that there is usually a neuropathic component associated with bone pain, in addition to the inflammatory and nociceptive component of bone pain. So this is a core diagnostic criteria for cancer-induced bone pain, which is a joint collaboration between Action and American Pain Society. So the criteria given is this is a core diagnostic criteria. Usually, at least one of them will be present in bone pain. So the background should be there should be a history of primary or metastatic bone cancer diagnosed during imaging and physical examination. So there should be a presence of continuous background pain, usually described as annoying, dull, aching pain in one or more locations, generally consistent with non-distribution of bone lesions, and there is usually a evoked sensation of pain in these locations where we know that there is bone mets, especially with weight bearing and movement. And clinical examination of that particular area can show some hyperalgesia to non-noxious pressure stimuli. There can be some hyposthesia to non-noxious thermal stimuli, hyposthesia to light touch stimuli, etc. So basically, there can be some neuropathy component along with the history of bone lesions, primary or metastatic bone lesions, along with the symptoms related to bone pain, that particular pain and aggravating of pain in that particular region in association with movements or weight bearing. So this is a core diagnostic criteria for cancer-related bone pain. So this Action APS has criteria for various chronic cancer-related pain. So this is a criteria for bone pain. So having said about the somatic pain, we'll come to visceral pain. So visceral pain usually happens when there is an obstruction of any hollow viscus. So it may not be always obstruction of hollow viscus. It can be because of injury to other pain-sensitive visceral structures like visceral pleura, hepatic capsule, or peritoneum, etc. Usually we see right hypochondrial pain in patients with liver mets or primary liver malignancies where there is a stretching of a liver capsule. So it can be because of hollow viscus obstruction or injury to the pain-sensitive visceral structures. It can be treatment related also. So especially when there is a previous surgery or a previous radiation to that particular area of involving bowel. So there may be adhesions and all those things there, which can actually contribute to visceral pain. So typically described as a colicky and twisting pain, but it is always important to keep in mind that when there is pain sensitive visceral structures like pleura and peritoneum involved, it may not be colicky and twisting. Pleural pain may be described as a pricking kind of pain. Hepatic capsule pain can be described as a dull aching pain also. But generally, if a hollow viscus is involved, colicky and twisting pain is a typical description of the pain. So, these are the various types and pathophysiology of pain. Etiology of pain can be disease, treatment, debility, or concurrent disorders. So, disease can be soft tissue, bone, nerve, viscera due to the disease involvement. Treatment-related pain like chemotherapy-related neuropathy, RT, chemo-induced mucositis, etc. Other debility like constipation and muscle spasm. It is also important. Concurrent disorders like osteoarthritis. So the reason for this particular slide is that in 15% of the patients with advanced cancers, none of pain is caused by the cancer itself. So sorry for the typo. None of their pain is what I meant. So it is always important to keep that just because a patient has advanced cancer, it doesn't mean that the pain experienced by the patient is entirely related to the disease itself. In 15% of the patients, even with advanced cancer, pain is absolutely not related to the cancer itself. So always important to keep in mind regarding the etiology of pain. There can be other things that we can easily sort out as well. So this is regarding the assessment of pain. So what are the barriers that we usually face when we assess pain? So there can be patient-related barriers and physician-related barriers. So patient-related barriers would be reluctance to report pain. So what we usually see is there is a widespread belief that suffering pain is actually a part of the treatment process. So many patients have the misconception that so it is actually part and parcel of the treatment. So we should just suffer it, just suck it up, and then don't complain about it. So second would be the fear of injections and medications, and especially with morphine and all those things, there is a widespread phobia. So fear of injections can be another barrier of reporting pain assessment. So belief that the pain is inevitable consequence and must be accepted, the thing I mentioned earlier. Cognitively impaired patients find it difficult to express their pain. Elderly and pediatric patients are another group of patients where there are barriers to effective communication and communication regarding proper pain. So there are certain physician-related barriers also. So if the most common thing is not being aware of the mechanisms of pain and the severity of the problem and all those things. So another thing would be language barrier. So especially when if you are working in an institute where patients coming from various states and all, we may find it difficult to communicate properly with the patient, which can again tamper our assessment of pain. So all those barriers are usually there. So the question would, uh, do we underestimate pain? So actually the evidence says yes. So there is one study conducted by Grossman et al. So they actually mentioned that when patients rate their pain as moderate to severe, oncology fellows fail to appreciate severity. So I just mentioned that I don't have anything about oncology fellows. Please don't feel like that way. This is just a pain. So I'll come to where we palliative care physicians stand as well in the next slide. So we are not in any position better than oncologists. So, but there is data which says that in 73% of the cases, we tend to underestimate moderate to severe pain. So another surveys uh, showed that discrepancy between patient and physician evaluation of severity is a major factor of inadequate pain relief. So we underestimating the pain is one of the major things that prevents adequate pain relief to our patients. Sorry. Yeah, this is another study which was conducted in a palliative care facility. So this is in a hospice actually, where pain management should be the paramount thing that we are looking into. One of the paramount things that we are looking into. It is in 28% of the patients, pain was overestimated, and 46% of the patients, pain was underestimated. And half of the underestimation was clinically meaningful compared with only 28% of the in compared to the overestimation, underestimation was more clinically meaningful. For patients with numerical rating scale more than 7, more than or equal to 7, pain underestimation was both clinically and statistically significant. So in terms with the previous study, whenever the pain is moderate to severe, so our underestimating pain plays a bigger role in actually giving a clinically significant benefit. This is actually a study conducted in a hospice where there were trained palliative care physicians. So we all are on the same page. I mean, palliative care physicians, actually speaking, are not in any higher position when assessing pain compared to all. So we all are guilty of underestimating. That is what I intended to say. So one of the most thing is, as we saw in the previous slides, one of the most important cause of discrepancy would be the difference in assessment between the self-reported pain and the physician's assessment. So that discrepancy is the main limiting factor. So I again like to underline the fact that self-report is the best report. Pain is a subjective experience. So whatever the patient reports, we should actually take into utmost importance above and definitely above our own assessment of the pain. So the uh, the lack of the presence of discrepancy between our own assessment and the patient's reported pain should not be a limiting factor. So self-report is the best report. So as in continuation to the previous barriers that we mentioned, other physician-related barriers like proper communication, failure to use validated pain measurement tools, lack of time committed to pain as a priority. All things can be the reasons why we underestimate pain in these patients. So these things should be also be looked into. So the thing is, using a validated pain measurement tool is important because it gives us an objective overview of how pain is actually progressing or regressing in our subsequent visits. So another thing I would like to mention is use help whenever possible. So as we saw, pain is a multi-dimensional experience which has psychological, emotional, social, all those domains. So whenever we have a help, whenever we have a nurse available, or a social worker available, or a psychologist available, so it is always important to use their help so that we'll get a more comprehensive assessment, and we can have like a more detailed assessment of pain, and we can actually design our strategy to control the pain better. Yeah, so I was to give another context. So treating pain is not only important for patient symptomatic relief, it is also important to us as clinicians. So especially when we are having detailed communication regarding prognosis, breaking bad news, and all those things. If a patient is in pain, so I mean we can all imagine if we are having a splitting headache. So how efficient would we be in processing information? So if you are attending a lecture or a class, and if you are a severe pain, so we may not be able to process half the information. So it is always important to address the pain. So what I intend to say with this slide is, so whenever a patient comes to us with severe pain, so rather than going into the next things of explaining about the disease and all those things, it would be hugely beneficial if we can address the pain better. So if a patient comes to us with severe pain, first do something for the pain, and then do all the things, all the assessments, or all those things. We can do it later. It will actually greatly improve the patient satisfaction, also better communication and better understanding of what we are trying to convey to those patients. So we'll end the presentation with a brief brief bird's eye view of adjuvant. So this is the basic pain pathway. So although we mentioned that tissue damage is not actually needed for pain sensation to happen, for this discussion, we just assume that there is one tissue damage. So from that area of tissue damage, the first order neurons will go to the dorsal root ganglion. From there, the ascending spinothalamic tract will take it to the thalamus. So then it will be transferred to the somatosensory cortex, where the pain is actually felt, the pain experience is felt. So from there, so there is a descending pathways coming down, which actually will decrease the pain sensation. So there is the down regulation of the pain. This is the upward communication of the pain. So basically, the analgesics that we usually use can be broadly classified as those which inhibit the ascending pain transmission, and those which facilitate the descending pain modulation. So the agents which actually inhibit the ascending pain modulation would be our typical analgesics like paracetamol, NSAIDs, opioids, ketamine, etc. So all those things will inhibit the ascending pain transmission. So adjuvants are the drugs which actually facilitate the pain inhibition via the descending pathways. So these drugs are anti-epileptics, antidepressants, etc. So these are the basic classification of the pain management medication. So analgesics basically the typical analgesics basically will inhibit the ascending pain. Adjuvants will actually the descending pain modulation. So basically adjuvants are not pain medications by definition. They are not analgesics by definition, but taken along with analgesics and certain situations, they can be very useful in providing adequate pain relief. For example, whenever there is a pain by edema, for example, there is a brain mets or a bone mets or a spinal cord compression. So where a tumor will always have a peri-tumor edema. So and there will always be some associated inflammation. So in such situations, steroids can actually help. So they will reduce the peri-tumor edema. They can also reduce the inflammation. So in such situations, steroids can be a very important tool to attaining pain relief. So that is regarding steroids as an adjuvant. Antidepressants and anticonvulsants can be very valuable in controlling neuropathic pain. So I would just add at this point is that, so if you feel that a patient has neuropathic pain, it doesn't mean that our typical analgesics like opioids do not have a role. So it is said that 30% of the neuropathic pains actually respond to opioids. So we usually give analgesics. Along with that, we can give adjuvants like antidepressants and anticonvulsants, like the basic usual drugs that we give, amitriptyline, pregabalin, gabapentin, all those things can be really beneficial in case of neuropathic pain. So in case of bowel colic, we can give antispasmodics, the usual things that we give like hyoscine butyl bromide and glycopyrrolate. All those things can be beneficial if there is a visceral pain and there is a bowel colic as a result of obstruction and something related to that. So if there are concurrent infection which are contributing to the inflammation and increasing of the pain, antibiotics can be really beneficial, and sedatives can especially be useful. I mean, the pain is actually causing insomnia and there is some terminal pain and all those things. So these are the usual classes of adjuvants. I'm pretty sure that adjuvants will be dealt in the coming classes. So this is basically a bird's eye view of adjuvants. So they are not analgesics as such, but certain situations when used along with analgesics, there can be a valuable tools. In general, they act by facilitating the descending pain down regulation pathways. So that is about adjuvants. So that is basically all the slides that I have prepared. So yeah, that's it. So if there is anything, any questions, so we'll discuss
Thank you so much, Dr. Jewell, for the excellent presentation. The session is open for questions. You can even ask questions by the chat box also. Dr. Jewell, can I ask a question?
Yeah, please,
How
please,
about,
please.
which pain scale you commonly use in your institution?
We use numerical rating scale, sir. But the thing is, we have a psychologist and a social worker in our team. Psychologist, social worker, and nurse in our team. So each new patient, I mean, each patient who comes to our OPD will be assessed by psychologist, nurse, and social worker. So basically, it's like we assess the various domains of pain. So as a tool for doctors in particular, we use only the numerical rating scale.
Okay, Dr. Ravi Kiran has a question, it seems. Dr. Ravi, please. Dr. Ravi, you have a question?
Good evening, sir. It's a very nice presentation. I would like to address regarding the distress thermometer. Am I audible?
Yeah.
Yeah. So regarding the distress, as we know, the word itself, distress, when we translate into a vernacular language, is a bit tricky as well as cumbersome. Suppose we go for the pain scale, we can ask how much is the pain or how it is. That would be translated easily. But when we come to address the distress thermometer, and we want to know the 0 to 10 scale, and when it synchronizes the same, the pain and the distress, even the sisters, they can't differentiate much when we ask, even ask the physicians as well. It becomes like what to use the correct word to know the 0 to 10 scale. And as in the NCCN thermometer, we says like a pain 0 to 10. Even at distance, we 0 to 10. So how can we have the demarcation line between the pain and the distress so that we can accurately the synchronize the distress thermometer, we are calculating the distress score, because the pain version also being into the same thing. I hope I'm able to express my doubt.
Yeah. So I mean, I would just like to tell that one thing is a distress thermometer, that is not a tool that we specifically use for pain management. I mean pain assessment. But the thing is, yeah, as you have rightly pointed out, is many a times it is, especially in a local language, it is very difficult to differentiate between pain and distress. So, but the thing is, we don't always need to. So if we know that the patient has pain, and if the patient is having distress, so basically what we are trying to measure is, distress is the total experience of the patient, something like a total pain. And pain is something, in that context, we are referring pain as a particular sensation and distress as the total experience of the patient. So if we know that the patient has pain and if the patient has distress at a particular level, so what we can do is we can address the pain and also look into the other various domains that are causing the pain. So it is not specifically needed to demarcate pain specifically from distress. So we need not tell that pain is this and distress is this, because pain is actually a contributing factor to distress. So the only thing is, different is distress. We cannot actually completely pinpoint to pain as a sensation. So it may be due to other factors as well. So for example, if the patient has severe pain and the distress thermometer is showing 6, so we need not actually tell that this 6 is because of pain or the thing. The thing that matters is the total experience of the patient is the distress. So that is actually severe. So pain may be a causative factor to that. So what we can do is we can address the pain with some medications, and we can look into the other factors, other domains which are contributing to the distress experience also. So it is true that in many things, numerical rating scale, we may not be able to differentiate between pain and distress, but we don't need to. So we can actually, in the subsequent visits, we can separately assess, and if the distress is coming down, we are on the right track. So even though we are not able to exactly differentiate, so we have an objective assessment of both the distress and the pain, and if it is coming down, so we are on the right. So that is all that matters. All that matters is the patient is
So,
getting better.
like if the pain score translate around 6 and 7, so the same way the distress will also be in the thermometer the 6 and 7.
Yeah.
You know, okay.
I didn't get you. So I didn't hear you. I mean,
If the pain score on the NRS shows around 6 and 7,
yeah.
so the distress also would automatically in the range of 5, 6, 7 something.
It may not be.
It's
So
like our
yeah.
estimation.
Yeah, the idea of using a distress thermometer along with pain score is that, so the pain scale and distress thermometer need not match. That is the only thing. So even if a patient having a pain score of 4 on 10 can have a distress of more than 6 or 7, so it can be because of other factors as well. So the what I why I mentioned distress thermometer is if the patient has other distress due to various other factors like social factors, it can actually affect the
Add on.
pain experience also. So the thing is,
So to the patient, what would we ask regarding when we go for the psycho-social assessment
yeah,
and we turn the page to the distress thermometer? What
yeah,
would we, in a layman language, that
yeah,
we can express our thing to the patient in
yeah.
the
So
distress thermometer?
for example, in the term I am practicing in Tamil Nadu. So the term that
Yeah.
we use in Tamil is எவ்வளோ கஷ்டம் உங்களுக்கு எவ்வளோ கஷ்டம் இருக்கு அப்படின்னு that is what we ask. That means custom is not exactly pain. We have a separate word for pain, that is we usually use vali, that is pain. Custom is the total distress that the patient. So that actually will depend on the patient, a person who is asking, and that will actually again vary from local language to local language. So the thing is, how we
So,
actually do is we review. We have team meetings, so and we discuss among ourselves how to communicate it properly to patients. Sometimes we find that what we are telling the patient, they are not able to understand. So in such cases, we try to explain to them. So the thing is that word is actually very difficult to define a particular word because it can actually vary from region to region, language to language. But it is important that we
yeah.
have a separate word for pain and distress. Otherwise, it will be very confusing.
Thank you, sir. Thank you.
Dr. Jewell, we have two more questions. One from Dr. Akhil Kapoor. That is, many a times patients with neuropathic pain are co-prescribed pregabalin and duloxetine. Significant proportion of patients develop sedation.
Yeah.
So what should be the best possible method or dose to start and upscale these drugs?
Yeah. So currently, the thing we usually practice is initially we start with a drug, one adjuvant, go up to its maximum dose. If it is not working, we actually add on another adjuvant. So that is what we usually do. So we don't usually in our clinical practice, we don't usually give a combination of drugs to start with. So we usually start with a single adjuvant and then go. So the usual dose of pregabalin we start with is 50 to 75 milligrams and then actually go up on this. So we usually go up to 150 milligram BD of pregabalin before adding on another drug. So that can actually vary from institution to institution. So again, that will be covered in covered in detail in the coming presentations, I suppose. But usually we don't give a cocktail of adjuvants in the first visit. We usually start with a single thing. We usually uptitrate the dose. The important thing here is we have to frequently review the patient to see how it is working. So we have to see whether the pain is coming down, the patient is sedated. That will actually depend on a great deal on how you review the patient, how frequent you review the patient. So the general guideline would be to start with a single adjuvant, go up on the dose. If it is not working, add on another adjuvant.
Okay, thank you. Doctor, another question from Dr. Ashwini. Which is the best module in pain severity assessment in oral mucositis in head and neck cancer due to radiotherapy treatment?
Yeah. The thing that I would like to mention here is whether it is a neuropathic pain or a pain due to mucositis, visceral pain, or whatever it is, bone pain, the way we assess the pain is the same. I mean, for all the pain, for the patients coming to our OPD, we use numerical rating scale for severity. So the assessment will help us to differentiate the pain, because the pain due to mucositis, radiation mucositis, the management would be different when compared to visceral pain. But the grading, the intensity scaling would be the same. It will be the numerical rating. So whatever rating scale you are using in the institution. So that won't differ according to the type of pain. Only the treatment is, the treatment will differ. So the drugs that we give will differ, the management will differ, but the scoring is the same. It is always the uh, whatever scale you use for all the things. So it won't change from either, whether it's a neuropathic pain or a visceral pain, bone pain. We usually score it from 1 to 10. That is what we usually do.
Okay, thank
I
you,
think
doctor.
that is clear. I mean, that's what Dr.
Yeah, clear, doctor. Thank you. Doctor, another question from Dr. Shraddha, but there is a topic we just discussed now. How to use distress thermometer. Do you have anything to add on it?
The thing is, it's this using distress thermometer is little bit more detailed than when we use pain, because it is usually maybe asking for pain is easy. How much pain you have, that is a question that almost everyone can understand. But how much distress you have is a little bit more difficult to express. So you have to find a proper word in your local language. You may have to talk a little bit to the patient. So you may need to explain what you mean by that. But when compared to that, asking how much is your pain is more of a straightforward question. It's easy to understand. The patient, almost all the patients can easily answer to that. But explaining what distress is and to find the right terminology to express it is a little bit difficult. So basically the idea is, if you can actually convey what you mean by distress, it is the same way as we rate scale. We actually ask the patient to rate it from a scale of 0 to 10. That's all it is. That's all it is. Distress thermometer is, it's like a numerical rating scale, but you measure distress other than pain. But the tricky part is to express what you mean by distress and to make the patient understand that it is like a total experience other than a particular sensation that you can pinpoint.
Correct, doctor. Thank you. And another question from Dr. Pooja Gupta. What is the ideal time interval to reassess pain response after prescribing analgesics in OPD basis?
Yeah, the thing is that actually will be definitely described in the coming sessions, I think, but I'll just tell you what it is. So, for example, that will depend on the drug that you give. For example, if you give morphine, immediate release morphine, it will actually take 36 hours to have a steady state blood level concentration. So we usually have to 36 to 72 hours is the time period we'll call back the patient. So we usually want the drug to have a steady level blood concentration before we hike up the dose. So that is the general principle. But if the patient have a very severe pain, you see the patient, you will actually call him back the next day, or you review in the ward the next day to see how the patient is. So that will actually depend on a lot of factors regarding the severity of the patient, severity of the pain, the drug that you give, the benefit that you are expecting from that treatment. All those things would be taken into consideration. So in general, if you ask if the patient is actually responding to the treatment that we are giving, 48 to 72 hours is the usual time that we call back the patient. Or if you feel that the patient pain is well controlled, even after 1 week, we usually we can call back the patient. That again, that will be like a tailored approach rather than having a general guideline. But again, you will want to wait until the drug reaches the steady state plasma concentration before going up the dose, as a general principle.
Thank you, doctor. Do we have more questions? If anyone has questions, we can put in the chat box, or you can unmute and ask directly. I think there are no more questions. We have almost 5 minutes to go. So can I summarize the session if there are no more questions?
Yes, I can.
Yeah, okay. So thank you, Dr. Jewell, for the excellent presentation and explanations to the questions. So he had explained well regarding the pain matrix in the brain, and the shocking thing that 94.3% of patients with severe pain do not have adequate pain relief. That's a shocking thing. And that the prevalence of pain in cancer patients is rising over the years. And that's why the importance of routine screening of pain in the OPD and the clinics. And he also explained about the general principles of the pain assessment, especially the open questions and giving more time for the patient and let the patient talk, and we'll watch for the visual clues. And more important, believing the patient and have empathy and comparison. Regarding assessment of pain, he explained very well regarding how we can practice it, like it's an history taking, and it's all an art which we can practice over time, then only we can master it. And regarding history taking and characteristics of the pain, the PQRST of the pain assessment, of course, it's very important. The tools used in the pain assessment that also was discussed, especially the unidimensional pain scales which we use routinely, and the multidimensional tools which are available, including the NCCN distress thermometer. And the pathophysiology of pain, especially the nociceptive part and the neuropathic part, was discussed. And regarding the diagnosis of the neuropathic pain, DN4 questionnaire that was discussed. There's a sympathetically mediated pain, and the nociceptive pain, the visceral pain, the bond pains that was described. And regarding the bond pains, the core diagnostic criteria for bond pain, cancer pains, that was discussed. And regarding etiology of the pain, especially the DTDC part, about the disease, the treatment related debility and other reasons. And the barriers to pain assessment also was described, especially the barriers from the patient side as well as from the clinician side. And especially he stressed on the self-reporting is the best report. Of course, that's very important because only the patient knows what the pain is, what his pain is or her pain is. And he also stressed the need for teamwork and asking for help, especially if you are in doubt whether the patient is having multiple issues. And also the importance of addressing the pain first on the first hand itself, that was also stressed. So he also gave an introduction to the adjuvants, and especially regarding the neuropathic pain management. So thank you so much, Dr. Jewell. And over to